Great. Well, this morning I'm going to talk just about one component of palliative care, and that's this issue around pain and pain relief, and look at some of the concepts of pain, but also look at why in a world when we can do so much and when we can explore what Mars looks like, when we can look at what Saturn is, what's happening on Saturn, we can look at we can create wars and change wars. Why can we not put pain relief into villages when people are dying and desperately needing support? And the difficulty of trying to describe pain, and I'm not going to give you any clinical or medical or physiological definitions, but often we think of pain very much as physical pain. But I also just want to flag up that there's emotional pain, mental pain, spiritual pain, and often as people come towards the end of their lives, these other components of pain play a huge part alongside the physical pain. But before I do, I'm going to talk about something that may seem completely separate to pain, and that's circumcision. It's a particular interest of mine, male circumcision. And I used to live in Kenya, and I was very involved with male circumcision rights for a particular purpose, because I was involved in putting together health education information for young boys who were being circumcised to become men. And this was in the 90s when HIV was rampant and when there was no antiretrovirals available really for the majority of people in sub-Saharan Africa. But the reason I'm flagging this is because it's to do with cultural attitudes. Pain in circumcision, everyone describes it as horrendous. Even Nelson Mandela talked about the pain as having fire shooting through his veins. But boys are taught that pain is to be endured. The boys in the area I worked in were all brought to a river. Those who were having traditional circumcision, they were brought into the river. They were made to stay in the river, so there was a numbing going on. When they come out, the one circumciser, traditional circumciser with the one knife, it was the 1990s when HIV, as I say, was rampant, would make the cuts. And any boy who cried out was regarded as still a child, not fit to be a man. So pain is very much something that many cultures push as you must endure it. It's a sign of manhood, but not just manhood, it's a sign also of womanhood. A lot of cultures suggest that really pain in childbirth, and having 2 children myself, it's a very painful experience, but pain in childbirth should be accepted. You should suffer in silence. Within India, a number of people have talked about bearing pain in silence is the component, what will shape the character of the child. The Bariba woman in Benin are told that those who fuss in childbirth are worse than the ant. And the Fulani talk about the need to suffer in silence, because that shows a good mother, a good wife. But actually, Dennis Walsh, whom I hope nobody's related to, did at one point, for reasons known to nobody but himself, comment that it's good for a woman to suffer the pain of a natural childbirth. I have to say that comment didn't endear him to 50% of the British population, and it was rephrased. But there is definitely an attitude that, yeah, pain is something to be endured. It's it's character building. Problem is, it's horrific. Pain when people are living towards death, and pain when people are suffering with diseases, when all they have is Panadol or paracetamol to chew, is horrific. And we all will die, and we'll all die very differently. And some of us will die with a lot of pain relief, with a lot of support, with a lot of systems in place, but some of us may not. And we know certainly there's a postcode lottery and there's a geographical lottery, because many will die very differently from how we would want people to die. Many will die better than others. Many will die in a worse way than others. Pain occurs in up to 70% of patients with advanced cancers and 65% of those with non-malignant diseases. We're not talking about a tiny minority of people who are dying with diseases who have pain. So many people are suffering with pain, and yet 4 out of 5 people in the world, according to the Human Rights Watch, don't actually have pain control. We're talking about 3.6 million with untreated pain, and as you can see, the majority in low-income countries. You think, what's going on? Why is that? Because we can do lots of things, and we've got huge interventions around malaria, and actually this morning we've got this message that actually we may have a malaria vaccine by 2015. We're putting it onto the market, which is extraordinary. There's been lots of reasons. Some are economic, but some are not economic. Some are actually lying behind an economic rationale. Some are about fear, about a whole system that we need to unpick. This is a map that shows morphine consumption in 1989. And you can see, the countries where there was a lot of morphine use, and then the countries where there was almost no. So if you don't want to be red, and actually the areas, the blank areas are where the data just wasn't available. But you can see that if you in so much of Africa, but a lot of South America, a lot of Asia as well, had very limited morphine, and this changed hugely over the last 10 years from 1999 to 2009. So you can see that there's been a huge shift in morphine availability, particularly in China, South Asia. But still, there's a need to push that further. Africa remains extraordinarily sparsely supported. I want to try, if I can, with Lisa's help, show you just a tiny little caption, which is done from Germany, and it shows over the last few years, from 1964 onwards, what was happening with morphine consumption in the different countries. So just watch. It's only a second or two, but you can see where countries are rising, where countries are decreasing. Sadly, Uganda and Nigeria, they look like little dancing sort of sticks, and you can't see much behind it because there's really almost none, but they're the two of the countries that actually have a little bit more morphine than most. And South Africa is different, because South Africa has had quite a bit of support, but still, as you can see here, according to the need, South Africa has gone down and down. And then you can see Europe. In Europe, Austria now has the highest, and we can't see Austria there, but it's the highest morphine consumption across the globe. So why is this? And why does it matter? Well, it matters, and as the human rights, the access to pain treatment as a human right, this report really talked and picked up this message: don't make us suffer anymore. So many people are calling out, you must do something, there must be a change. And there's so many barriers. Barriers are around this national drug laws and regulations, fear of addiction, poorly developed healthcare systems, lack of knowledge. We're going to unpick some of those a little bit and see what lies behind them. Now, this doesn't. I'm not a lawyer, and I'm not terribly good at explaining legal stuff. So the next few slides are probably going to seem quite dry. But we know within WHO and within the national legislation, there's been a real push to say that national drug control policies should recognise that controlled medicines are absolutely necessary for these medical and scientific purposes. But often, what you find, if hospitals do have morphine, they're in a cupboard, poisonous drugs cupboard, locked up with no availability. And in so many hospitals, where cupboards like this are, the question is, when you need the morphine, who's got the key? And the person with the key is not around. Morphine, it being seen as very, very much something that we've got to keep locked. Now, as I say, Article 12 of the International Covenant on Economic, Social and Cultural Rights really does state the need all nations, all states should ensure access to essential medicines included in the WHO list of essential medicines. And in fact, there's been a new list come out that really stresses these are essential palliative care medicines. So you've got this high-level message saying this is necessary. Countries have the right. Countries must. Countries should. And oral morphine is included in this. But within this drug control framework, it's based on 3 treaties, and this sense that there's 2 things happening. States must ensure access to the narcotics for medical purposes, but states also must combat diversion of narcotics into non-medical use. So states are constantly trying to balance the fact, and with the drug war that's going on, with so much media attention around drug abuse, many states are much more concerned about the control element than the availability element. So each nation themselves needs to create their domestic laws which actually comply with International Narcotics Control Board. Now, alongside that, you've got Article 19 and 20 of this single convention on narcotic drugs. And one states that on the basis of adequate statistics, every state needs to submit an overview of their estimated need for narcotic drugs for medical purposes. So states can't just order in and think, oh, well, I'm just going to get a little bit more of this week and a little bit more of that next week. There needs to be an agreed report put together based on need. And they need to record every time a substance is administered to a patient or used for medical purposes. Now, the reason I'm going through all this is because it really does begin to make sense of what's happening. And a question I want to ask you is, how do we change this? How do we make sure that, not that we change the law, but how do we make sure that the law is supported in such a way in countries that we actually can ensure morphine gets to the village? Because that's the key issue. How do you get a pain relief, adequate pain relief, to the people who need it, who don't have transport, who don't have someone who can carry them to hospital, who don't have the money to get to hospital. So, and also alongside this legislation, you've got another message that's saying that the single convention on narcotic drugs requires everybody to have this, to be licensed to handle opioid medications. But interestingly, it doesn't actually ask for a separate license. It just asks that people are licensed. And the majority of countries, like ourselves, we identify a medical practitioner as someone who is licensed to work with opioid medications. And many countries move forward and they require a special license. So they start to minimise the number of people who can actually hold morphine in their hands. And it becomes more and more restrictive. They limit it sometimes around disciplines. So Egypt, Ukraine, Georgia, limited to oncology, pain management. And as you see here, only 2 of the 40 countries, and that's Uganda, interestingly, and the UK allow nurses to prescribe controlled medicines. So South Africa is just pushing through at the minute a nurse prescribing system. So what within the sub-Saharan African context are the various beliefs about morphine? From a number of doctors, and these were from some of the interviews. But one of the tragic things was in this quote on the side. It was from one of the practitioners in Uganda, and this is a country that actually, given within the context of Africa, is the most ahead. But they said, yeah, I mean, the users, they become dependent, and that's a problem for not using it. And when they was asked to push this further, where did this data? Where was the evidence base? He said, actually, it's well documented in the motion pictures, widely publicised. He said, we've seen it in the Bollywood pictures and Nollywood from Nigeria, and that really tells us that morphine use is addictive and you don't want to be using it with patients who are dying. Going, okay, that's an interesting evidence base, but actually it's not one. Let's look back and unpick that. But I put that quote in because so many people are being influenced by media to believe that's what's the situation. There's also views that tolerance to morphine occurs rapidly, so delay giving it to the absolute end, so you're going to get the maximum benefit before the patient gasps and has that last breath. Patients taking morphine are at risk of becoming addicted. That's probably the strongest belief right across the country. And morphine masks the signs and symptoms of disease progression. So therefore, clinically, it's very hard then to know what to do if you've given someone morphine. Morphine causes respiratory depression. It's liable to misuse. It's an expensive medication. It's difficult to access. Some of these are true, but this is the system. And that, an empty cupboard, that probably reflects pain relief in so many hospitals in so many parts of Africa. And families also, if clinicians are believing this, families also have very strong beliefs. So even when clinicians have identified and given patients morphine, a lot of families don't want to use the morphine, they don't want to carry it, they don't want the patient to be seen in the community as someone who takes morphine. Lots of reasons, some religious, some people are saying, well, you know, if the patient dies when they are using morphine, then they won't go into Allah's presence with a clean mind, and therefore that's wrong, and that the Quran forbids that. And others fear that it will become too costly, that the patient will become addicted, they'll not be able to manage the addiction, the patient will become more and more rambling and mad. And all of this is because there's not adequate information. And yet, as I say, morphine's so cheap, so cheap. One of the cheapest drugs there's about, one of the most effective drugs. What do we do? The thing is, the reason that this is so important at this time is because within sub-Saharan Africa, we're seeing this different burden of disease. We talk about a double burden. We've got the infectious disease is still there because the majority of sub-Saharan African have not got rid of malaria. TB is on the rise again, particularly drug-resistant TB. We've got a non-communicable disease burden coming across on top of the infectious disease burden. And many of you are so aware of that. And we've got this, you know, almost this sort of spiral happening, this gyre, because these two groups of, massive groups of diseases are interacting with each other. So colon multimorbidity is shaping the health of Africa, just as it's shaping multimorbidity from NCDs is shaping the health of the West. We're seeing in Africa many people who are HIV positive, who also got cardiovascular disease, who also have got diabetes, who also have COPD. So you're getting a real mix of disease profiles. And we're seeing new types of diabetes, new presentations that don't quite fit. Type 2 diabetes with the young, thin, slender African man in his 40s. What's going on there? There's increasingly folks are saying there's something very different about the African profile of a number of diseases. Some of that is connected to infection, some connected to famine, some connected to this intersection of drugs and treatment regimes that people have been using. But all of this is saying we need to ensure palliative care is in the system. Now, I just want you, if you can, to watch this little video, because it says it far better than me about why we actually need to work together. Okay, thanks. There's a series of videos, and some of them are, there's about 40 from their life before death, and they're worth looking at. I just wanted to capture one of those there. Thanks, Lisa. So, in the last little bit of time, I want to talk about, well, what's happening? Because there's some amazing things happening. And then I want to talk about some of our other research, picking up areas alongside physical pain that we need to address. We work very closely with Malago Hospital in Kampala as part of a big programme on palliative care. And Malago has really pushed forward around introducing oral morphine, and actually also training the staff, linked nurse staff on each ward to be able to identify who across the wards needs morphine, who needs palliative care. In a survey that was done in the hospital in medical and surgical wards, there was a shocking 45% of the patients within those two wards, and we're not talking about two small wards, we're talking about two groups of huge wards together. But 45% actually of patients in those wards had palliative care needs. They were living with illnesses that weren't curable. They were dying, and very few had any sort of pain relief at all. This is not a great slide, I appreciate. But I want to say, on the 18th of September, just 2 weeks ago, I was in South Africa, in Johannesburg, for the African Palliative Care Conference. And one of the really exciting things about this conference was that a number of ministries from across Africa were invited to make a declaration, ministries of health, to declare and pledge that they together would look at strengthening and putting in palliative care within the health systems. And it's something that we have a programme, and I'll talk a little bit at the end, funded by DFID through THET for health system strengthening in palliative care. And as part of this, African ministers have really saying, we want to take this forward as a global issue. We in Africa are going to put this onto the global health agenda. And you can see the declaration with a really strong message that actually we need to put pain relief into the system alongside all of the conditions that palliative care required. So that we get to situations like this where a nurse is moving about carrying, this is morphine on the table, because morphine often can be made up with solution, with saline water, very easily made up with the proper controls, and made very easily available and brought out to patients and communities. So there's huge changes happening. Community sensitisation, families are being empowered to understand what's going on. Generalist training is happening, and part of the programme is very much about training doctors right across and nurses to recognise need and then to put into place within curriculums. And part of our programme is looking at how do we support nursing curriculums, how do we support medical curriculums in the countries we're working in the 4 countries, Kenya, Uganda, Zambia and Rwanda, to actually train practitioners as they come through their health worker training to see the need, to see the importance. So I'm going to just talk a little bit about 2 studies. One's a very old study, in fact, that Scott Murray and I carried out, and it was published in 2003, and you might wonder, why am I mentioning this again? But it actually is still one of the studies that comes up again and again around what are the issues, the bigger issues about pain. And the other is a study that we carried out in Kenya, Uganda and Malawi within rural communities, actually trying to pick up what various people were saying about their needs. In that study, looking in the rural communities, it was using rapid evaluation field techniques. We were capturing data from a number of key informants, also with photographic ethnography to see how people were reacting, what was happening, what was on the ground, comparing that to local reports and stats to put together a triangulated picture of evidence. And this is just a number of participants who were taking part in the study across the countries. And one of the extraordinary things was that when so many people were identifying what it is, what is the most important thing, what matters, and you can see in these quotations patients just describing what it feels like. And then particularly this patient from Uganda, her mother talking about when Jess got some morphine, it brought back her happiness, a sense that actually not just patients but families will feel differently if the pain is relieved. One of the reasons that I'm involved in palliative care, and one of the reasons for me that it's so important, is because of an experience I had when I worked in Kenya. And it was when two things happened. One, a woman saying to me, as part of a study I was interviewing, I was talking to her about her needs, and she said, I want to go to sleep and wake up dead because the pain is so great. I thought, to be at that point, you're saying, I want my life over. I want to go to sleep and wake up dead. And another woman who was when I went to see her, she was lying in feces, there was maggots under her, she was in such pain, she had such horrendous wounds. She was really struggling. She was in tears and screaming. And when we gave her morphine, that did help. But you thought, morphine's only part of this. We need a system. No one can be left to lie like this. The family were looking after her as best they could, but they couldn't because there wasn't enough support. There was no sheets in the bed because there was no sheets in the family. It was in a small hut. There was no cloths on the little line that went across her bedroom. And bedroom's the wrong way to describe it. It was a little part of the hut that was divided, and there was a small sort of string that was attached across the ceiling, and her little bits of clothes were there. And when we washed her, we had to take some of those clothes just to wash because there was no towels, there was nothing. You think, how do you manage in families Families who are desperately trying to care. How do we manage to actually support a family when a patient is living like that and dying, and also so terribly anxious not to be a burden to their family? Other important things. So much of pain is not just about the morphine. It's about how we react to people. It's how we value people. It's how we understand their emotional pain and their spiritual pain, how we understand the pain it feels like to actually lose your life, the pain it feels like to be the burden and to think that others are looking at us and we're costing the family a huge amount. And it's one of the important things, don't ever estimate the cost of dying in Africa. We think in the West the cost of dying is huge. In Africa it is also huge because families often are not told the patient has an illness that's not incurable. So they keep searching for cures. And even after they've searched for cures and it's clear the patient is not going to get better, the cost of getting maybe the patient to the hospital because you're desperate to have that patient in the hospital before they die, because you know that if they're in the hospital, then they can be put into the mortuary and the body can be kept there until you can call the relatives from different parts of the globe often, or certainly different parts of the country, because in our globalised world, families don't live together any longer. And yet, in so many cultures, it's important for all of the family to be there, to be buried together, to be part, so that they can say goodbye. So people need to be in the mortuary, and it costs. So there's multiple layers of costs that happen around dying. A longing for someone to bear the burden. That's what, and one of the exciting things around the training for community health workers, understanding more about palliative care and about giving care, was some of the nurses really talked about, for them, they wanted to make sure nobody died alone, nobody died neglected, and they described situations of having gone into homes and found people who were very neglected, who had been left. Nothing had happened because there was just no system to care. Also about addressing the pain that relatives feel, because not just in the whole team and the family are connected as folks die, and often, and maybe sometimes here in our cultures as well, we don't address that pain adequately. We don't think through what is it like for someone to lose? What's it like for a team member to also to lose those that they're caring for? But I was so struck with some of the training, and a Kenyan nurse who talked to me and was saying to the patient, well, we say it's okay because we're together, even if your husband's going to die. We're together in this. We're going to work it together. And I say, really capturing what the support that home care workers need, the support that volunteers need. And this is just one of the examples of some of the volunteers coming in and trying to and working and supporting. And unfortunately, I don't think this hasn't come through so well, because there's four pictures there. The need is huge. The need for actually reducing pain, the need to be with people is huge. I mentioned the study in 2000 that was published in 2003. It's this Kenyan Edinburgh study, Chigoria Hospital, where I was working, and here Professor Scott Murray was looking at a very similar study. And the reason I put it up is because there's differences, as you would expect. In Kenya, the main issue was pain. It was all of these, that analgesia was unaffordable. And yet, here in Edinburgh, the main issue wasn't pain, because for many people their pain was controlled. The main issue was this fear of death, was this existential sort of, emptiness, was this sense of where am I going, what's happening, how can I manage? And that came out time and time again, that folks were saying, well, we have lots of support, but we don't really know where we're going. And these are just some of the quotations from that study, which really capture this other sort of pain that's often not so easily addressed, as you can see. And I'm going to go back here to this study, because one important thing around the Kenyan study was that despite the absence of pain relief in many places, church groups, community groups, communities were coming together to actually provide some of the link, bringing little gifts, bringing small things just to be part of it. So, as I'm just closing now, can we learn from what's happening in other countries? Can we learn from our colleagues, our partners, those who are suffering in many sub-Saharan African countries? Can we also be part of this change to make things different? I think we can, and some of those messages are around accepting death as a path we all must tread, recognising the commonality of it. Being in community, though, supported by community, makes a difference. But being in community requires us to be part of something, to take action, to be able to share, not just to assume there's a community out there. It'll do us fine once we come to the end of life. I mentioned this programme, which is our Integrate programme, the DFID funded programme, and if you want to know more about it, there's a website on our Global Health Academy website itself that you can find, which provides information around the 4-country programme. And I'm going to stop with one really strong message, and that is that despite all that's happening, mobile technology is changing the way we can deliver palliative care, but it's also going to change the way that palliative care is on our global health agenda. Because there's a lot, if you go onto any of the palliative care sites now, there's a huge amount of tweeting, there's a huge amount of work going on about putting palliative care out there, making people understand the need, but also in a very local way. So this is one of the health workers who's using his mobile phone to get a report, to talk into the nurses, to say, I'm with this old lady, she's needing this, she's needing something else, what should we do? So the opportunity to use mobile phones to change and to create a sort of pathway of follow-up, a method of getting together people, something that means that this lady and so many others don't have to travel miles with no proper transport to get to a hospital. The phones can make a change. And one of the things that community health workers have very creatively done is something called flashing, where a health worker will flash into the nurse. The call will never be picked up. I mean, it'll never be answered because that would involve a credit. But the nurse will know immediately, this community health worker, she's trying to get a hold of me, I'll ring her back. So you've got this whole system that's working in a very, very resource-poor place, working with almost no money, but it allows people to talk. It allows people to work out where is there a bit of credit on the phone, there's a bit of credit in the hospital, we can ring out, we can manage. So with that, I'll stop, and thank you for listening, and thank you for being part of this agenda to put palliative care on the global health agenda. Thanks.